Sodium is the major cation of the extracellular fluid. It plays a critical role in maintaining osmotic pressure, which controls how water moves in and out of cells. About 85% of sodium is reabsorbed in the kidney tubules. The normal reference range for sodium is approximately 135 to 145 millimoles per liter. When sodium levels drop too low, we call this hyponatremia. This can be seen in conditions such as diabetic metabolic acidosis, diarrhea, Addison's disease, and renal tubular disease. On the other hand, when sodium levels rise too high, this is hypernatremia. It may occur in Cushing's syndrome, dehydration, hyperaldosteronism, or during insulin treatment for uncontrolled diabetes. Sodium is measured using an ion-selective electrode. A glass electrode is specifically selective for sodium. In the direct method, the sample is not diluted. In the indirect method, the sample is diluted, which may give falsely low results in patients with very high triglycerides or proteins. This condition is called pseudohyponatremia. Potassium is the major cation inside cells, making it the primary intracellular cation. Its normal range in plasma is about 3.5 to 5 millimoles per liter. Importantly, potassium is about 23 times more concentrated inside cells than in plasma, highlighting its role in nerve impulses and muscle contraction. When we are dealing with potassium testing, proper specimen handling is critical. Serum must be separated from cells quickly to prevent potassium from shifting into the serum. Several factors can cause a false elevation, known as pseudohyperkalemia. These include hemolysis, contamination with EDTA, prolonged use of a tourniquet, or excessive squeezing and fist clenching during collection. Very high white blood cell counts or platelet counts may also falsely elevate potassium, so in those cases, potassium should be retested using plasma. Keep in mind that plasma and whole blood potassium are slightly lower than serum values because potassium is released from platelets during clotting. Both hypokalemia and hyperkalemia are dangerous because they can lead to heart arrhythmias, muscle weakness, or paralysis. Hypokalemia, or decreased potassium, may occur with insulin injections, alkalosis, gastrointestinal losses such as diarrhea and vomiting, hyperaldosteronism, or Cushing's syndrome. Sometimes it can also be associated with tetany. On the other hand, hyperkalemia, or increased potassium, may be seen in diabetic acidosis, intravascular hemolysis, severe burns, renal failure, and Addison's disease. Finally, potassium levels are most accurately measured using an ion-selective electrode with a valinomycin membrane, which selectively binds potassium ions for detection. Chloride is a major anion of extracellular fluid. It plays a vital role in maintaining hydration, osmotic pressure, and the normal balance between anions and cations in the body. The normal reference range for chloride is between 98 and 106 millimoles per liter. In most cases, chloride levels increase or decrease in the same direction as sodium. When chloride levels are low, this condition is called hypochloremia. It can occur in several clinical situations. Diabetic acidosis, where there is excessive acid production. Chronic pyelonephritis, a long-term kidney infection. Prolonged vomiting, where gastric hydrochloric acid is lost. And in cases of aldosterone deficiency. On the other hand, elevated chloride levels are known as hyperchloremia. This may be seen in prolonged diarrhea due to loss of bicarbonate, renal tubular acidosis, or adrenocortical hyperfunction, which alters electrolyte handling. Several methods are used to measure chloride in the laboratory. Ion-selective electrodes, which use a silver chloride reference electrode. Coulometric titration, where silver ions are generated to bind chloride. And colorimetry, such as the automated thiocyanate method, producing a reddish color with a peak absorbance at 480 nanometers. An important clinical test is the sweat chloride test, particularly in diagnosing cystic fibrosis. In this test, sweat is collected by iontophoresis using pilocarpine to stimulate sweating. A chloride level greater than 60 millimoles per liter is highly indicative of cystic fibrosis. Then, we have the concept of the chloride shift. This is part of the blood buffering system that helps maintain acid-base balance. During this process, bicarbonate is pulled out of red blood cells, while chloride moves into them. As a result, serum chloride decreases. The anion gap is a calculation that reflects the balance between the unmeasured cations and the anions in the blood. It serves as an important quality control check when measuring electrolytes. If multiple patients show abnormal values, it may suggest an issue with the electrolyte testing process rather than a true clinical condition. The body has several unmeasured ions. The major unmeasured cations include potassium, calcium, and magnesium. The major unmeasured anions include albumin, sulfate, and phosphate. There are two commonly used formulas for calculating the anion gap. One includes potassium and is calculated as sodium plus potassium minus the sum of chloride and bicarbonate. The second, more widely used, excludes potassium and is calculated as sodium minus the sum of chloride and bicarbonate. The reference range for the anion gap depends on the formula used. When potassium is included, the range is approximately 10 to 20 millimoles per liter. When potassium is excluded, the reference range is 7 to 16 millimoles per liter. An increased anion gap indicates an accumulation of unmeasured anions. This can be due to conditions such as alcohol or salicylate poisoning, diabetic ketoacidosis where ketones build up, or lactic acidosis. It can also occur when unmeasured cation like magnesium or calcium are decreased. A decreased anion gap is less common. It may result from a loss of albumin, which reduces unmeasured anion, or from an increase in unmeasured cations such as elevated magnesium, elevated calcium, or in patients receiving lithium therapy. Hemodilution can also lower the anion gap. This calculation is a valuable tool for identifying and monitoring metabolic disorders and for ensuring accuracy in laboratory testing. When thinking about conditions that cause an increase in unmeasured anions, you can use the simple mnemonic SLUMPED. S stands for salicylate intoxication. This occurs with aspirin overdose, which produces excess acids. L is for lactic acidosis, a buildup of lactic acid from hypoxia or sepsis. U reminds us of unmeasured ions, substances not normally accounted for in routine lab measurements. M represents methanol, a toxic alcohol that can lead to severe metabolic acidosis. P stands for polyethylene glycol, another compound that contributes to acidosis. E is for ethanol, which in excess can shift acid-base balance. D represents diabetic ketoacidosis, where ketones accumulate due to uncontrolled diabetes. So, remember, conditions that raise the anion gap can be recalled with slumped. Salicylates, lactic acidosis, unmeasured ions, methanol, polyethylene glycol, ethanol, and diabetic ketoacidosis. Osmolality is a measure of the total concentration of dissolved particles in a solution. What's important to note is that the type, size, or weight of the particle does not matter. Osmolality simply reflects how many dissolved particles are present. There are direct methods used to measure osmolality. The two practical approaches are freezing point depression, which is the most precise, and vapor pressure depression. Both of these are based on colligative properties. A commonly used calculation for serum osmolality is 2 times the sodium concentration plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. This equation gives a good estimate of what the serum osmolality should be. When comparing the calculated osmolality to the measured osmolality, we can determine the osmolar gap. If the measured osmolality is more than 10 units higher than the calculated value, it suggests the presence of unmeasured substances in the blood. These include methanol, ethanol, or ketone bodies. Urine osmolality is also important. It is considered the best test to evaluate renal tubular function. Additionally, the urine to serum osmolality ratio tells us how well the kidneys can concentrate the glomerular filtrate, which is critical in assessing kidney performance. Magnesium acts as a calcium channel blocking agent, which means it has important effects on the heart. Levels of magnesium are often elevated in patients with renal failure. Increased magnesium may also be seen in conditions such as cardiac disorders, diabetes mellitus, and in those using diuretics, alcohol, or certain medications. Magnesium abnormalities are also associated with tetany. Laboratory methods for measuring magnesium include atomic absorption and several colorimetric techniques, such as Calmagite, Formazan, methylthymol blue, or Megan-based methods. Calcium combines with phosphate to form the structure of bones and teeth. In the blood, calcium is distributed in three forms. About 45% is bound to proteins such as albumin, another 45% is ionized and biologically active, and around 10% is complexed with other substances. Calcium is regulated by three major hormones. Parathyroid hormone increases calcium levels. Calcitonin works in the opposite way, decreasing calcium by inhibiting bone resorption. Vitamin D increases intestinal absorption of calcium and also helps in bone regulation. When calcium levels are too high, patients may experience muscle weakness and disorientation. Causes of hyperkalemia include hyperparathyroidism, cancers with bone metastasis, multiple myeloma, and renal failure. Low calcium or hypokalemia can present with tetany. Causes include hypoparathyroidism, low serum albumin, and vitamin D deficiency due to malabsorption or poor dietary intake. In these cases, calcium release from bone and renal reabsorption are impaired. The reference method for calcium measurement is atomic absorption spectroscopy. The most common laboratory method, however, is colorimetry, where calcium reacts with ocresulphthalene to produce a reddish complex. To prevent interference from magnesium, 8-hydroxyquinoline is added. Ion-selective electrodes can also be used to measure ionized calcium. These are pH-dependent, so samples should be collected anaerobically to prevent carbon dioxide loss, which would alter pH. It is important to note that most methods measure total calcium, including the protein-bound fraction. Therefore, high protein levels may falsely elevate calcium results, while using EDTA or oxalate as anticoagulants may falsely decrease calcium due to binding. Let's talk about tetany and its connection to electrolytes. When a patient presents with tetany, the very first electrolyte you should suspect is calcium. A drop in calcium levels is the leading cause of tetany. If calcium levels are normal, then the next step is to evaluate magnesium. Low magnesium can also lead to muscle spasms and tetany-like symptoms. Finally, if both calcium and magnesium are within normal limits, turn your attention to potassium. Low potassium can also contribute to neuromuscular irritability. So, the order to remember is: check calcium first, then magnesium, and lastly, potassium. Most of the phosphate in the body is expressed as phosphorus, but in the laboratory we only measure inorganic phosphate. Its levels are controlled by the parathyroid hormone. Importantly, phosphate has an inverse relationship with calcium. When calcium levels are low, phosphate is high, and when calcium is high, phosphate drops. When phosphate levels are increased, common causes include hypoparathyroidism, chronic renal failure, and excess vitamin D. On the other hand, when phosphate levels are decreased, we think about hyperparathyroidism and impaired renal absorption. Finally, how do we measure phosphate in the lab? The most common method is spectrophotometry using molybdate. In this process, molybdate binds to phosphate ions. Then, through a reduction step, molybdenum blue is formed, which we can detect and measure. Let's discuss the key regulators of calcium and phosphorus levels in the body: vitamin D, parathyroid hormone, and procalcitonin. Let's begin with vitamin D. Although we often call it a vitamin, vitamin D functions more like a prohormone. It exists in two main forms. The first is vitamin D2, or ergocalciferol, which comes from dietary sources such as fish, plants, and fungi. The second is vitamin D3, or cholecalciferol, which is mainly produced in the skin through photosynthesis after exposure to sunlight, but can also be found in animal-based foods. Both forms are converted into the active form, known as 1,25-dihydroxyvitamin D, in a two-step process. The first step takes place in the liver, producing 25-hydroxyvitamin D, and the second step occurs in the kidneys. The active form of vitamin D plays a critical role in increasing blood calcium and phosphorus levels. It does this by boosting intestinal absorption, enhancing renal reabsorption, and promoting bone mineralization. When vitamin D levels are deficient, several problems can arise. In children, deficiency leads to rickets, which causes soft and weak bones. In adults, it can lead to osteopenia and osteoporosis. Vitamin D deficiency is also linked to many other conditions, including hypertension, obesity, diabetes, cardiovascular disease, multiple sclerosis, cancer, autism, lupus, and autoimmune disorders. To properly assess vitamin D status, the best test is the measurement of serum 25-hydroxyvitamin D. Laboratory methods include immunoassays, high-performance liquid chromatography, and liquid chromatography tandem mass spectrometry. Next, let's move on to parathyroid hormone, or PTH. This hormone is synthesized by the parathyroid glands. Its production is stimulated when calcium levels are low and suppressed when calcium levels are high. PTH acts to raise blood calcium by stimulating bone resorption, increasing renal tubular reabsorption of calcium, and promoting the kidney's conversion of vitamin D into its active form. In surgical settings, intraoperative PTH monitoring is a valuable tool. By rapidly measuring PTH at the point of care, surgeons can confirm whether abnormal parathyroid tissue has been successfully removed. Typically, baseline plasma PTH is measured before excision, and then again at 5 and 10 minutes after removal. A drop of more than 50% within this time frame strongly indicates successful surgery. Finally, let's discuss procalcitonin, or PCT. Procalcitonin is normally made in the thyroid and is then converted to calcitonin, a hormone that lowers blood calcium levels. Interestingly, procalcitonin also plays a role outside of calcium regulation. It has become an important biomarker in sepsis management. While it should not be used to diagnose sepsis directly, it is highly useful in ruling out sepsis and guiding antimicrobial stewardship by helping clinicians decide when antibiotics are truly necessary. Iron is an essential element in the body, with more than 65% of it found in hemoglobin, where it plays a critical role in transporting oxygen. Iron is transported in the blood by proteins such as transferrin, haptoglobin, and hemopexin. For storage, the body keeps iron in two primary forms, ferritin and hemosiderin. When it comes to laboratory methods, serum iron is typically measured using colorimetric techniques, but it is important to avoid hemolysis because that can falsely increase results. Another key test is the total iron binding capacity, or TIBC. This reflects transferrin levels in the blood. The test involves adding excess ferric salts to the serum to saturate the binding sites on transferrin. Any unbound iron is then precipitated with magnesium carbonate, and after centrifugation, the supernatant is analyzed for iron. Direct methods for measuring transferrin use immunochemical techniques such as nephelometry. Ferritin measurement is also important because it reflects iron storage. Immunoassay methods are used for ferritin testing, and ferritin is considered a very sensitive marker for detecting iron deficiency. However, ferritin levels can also be elevated in cases of infection, inflammation, or chronic diseases, which must be considered when interpreting results. Let's review the laboratory assessment of iron, focusing on how different diseases affect iron parameters. First, let's begin with normal reference ranges. In healthy individuals, serum iron is about 65 to 175 micrograms per deciliter in males and 50 to 170 in females. Transferrin saturation normally falls between 20 and 55%. The total iron binding capacity, or TIBC, is about 250 to 425 micrograms per deciliter. Serum ferritin, which reflects storage, is 20 to 250 nanograms per milliliter in males and 10 to 120 in females. Next, let's look at storage iron depletion without anemia. Here, serum iron, transferrin saturation, and TIBC remain normal. The key finding is that ferritin is decreased, showing that iron stores are low even before anemia develops. In iron deficiency anemia, all of the iron parameters shift. Serum iron decreases, transferrin saturation decreases, TIBC increases as the body tries to bind more iron, and ferritin decreases significantly, reflecting depleted storage. Now, in anemia of chronic disease or inflammation, the pattern is a bit different. Serum iron is decreased, transferrin saturation is decreased, and TIBC is also decreased, unlike in iron deficiency. Ferritin, however, is increased because it is an acute phase reactant, rising in inflammatory states. In thalassemia, iron overload can occur. Serum iron is increased, transferrin saturation is increased, TIBC is usually normal, and ferritin is elevated. Hemochromatosis is another condition with iron overload. Serum iron is elevated, transferrin saturation is elevated, TIBC decreases, and ferritin is markedly elevated due to excess storage. Finally, in sideroblastic anemia, we again see increased serum iron, increased transferrin saturation, normal TIBC, and elevated ferritin levels.